talk about immunity, inflammation, and infection. I know that we have already taken the exam on this because you did have the reading required, but I did want to go ahead and lecture on this for you because I know that it benefits some of you guys to be able to hear me say it. So, immunity. Immunity is the ability of an organism to resist a particular infection or toxin by the action of specific antibodies or sensitized white blood cells. We have different types of immune responses. The innate immunity is nonspecific defense mechanism that come into play immediately or within hours of an antigen's appearance. Some examples would be the skin and chemicals in the blood. Active acquired immunity occurs when the person is exposed to a live pathogen and develops the disease and then becomes immune as the result of that. Active acquired immunity examples, I would be thinking something along the lines of chickenpox when the patient has actually had it. In my generation, we didn't get the varicella shot, the chickenpox shot, because most of us had chickenpox. Nowadays, our children, we give them the varicella injection. Acquired usually takes time. So anytime you see that word acquired, you want to think it's not like an instant kind of thing, an instant kind of immunity. And then we have passive acquired immunity. When a person is given antibodies to a disease rather than producing them through his or her own immune system. That's when we're thinking of passive acquired immunity. So older adults, they may have insufficient antibodies that have already been produced. So these antibodies have already been produced, but they're insufficient. This is when we need to look at booster shots to achieve adequate coverage against some of these things that we're able to vaccinate against. Older adults also have decreased immune function. So when assessing an older adult, the nurse should assess for specific signs of infection. So checking their temperature may not always be the best thing to determine whether or not the patient has an infection. Your slide there, I have a suppressed immune response slide. Primary immunodeficiency. So this is just talking about a part of the immune system is missing or not functioning properly. And then secondary immune deficiency is there's intentional or adverse effect of treatment. So just be thinking in your head, what are some things that could fall under that intentional, and what are some things that could fall under that adverse effect of treatment? For exaggerated immune response, there are 4 types of exaggerated immune response. And in your MedSurg book, I want you to look at page 221, table 23. And just take a look at that table because that gives a good explanation of that. And then we have hypersensitive reactions. This can be localized effects, and localized means what? When we hear the word localized, we should think it kind of stays put. It's local. So if we're talking about a person that is local, we mean that's a person that lives close to where we're living or that's close to whatever we're talking about. So localized means it stays at that site. It stays in that one particular area. Systemic effects, that affects the body in general. So it can affect multiple areas of the body. If something is having a systemic effect, we're going to note different areas of the body that are affected. Some consequences of the suppressed immune system. There's 2 major types of problems that result from suppressed immune responses, and those would be infection and cancer. So what is the link between a suppressed immune response and these consequences? Consequences of exaggerated immune response. Acute hypersensitive reaction, that can be localized or systemic. And chronic body-wide system disease. So under this, I want you to be thinking about destruction of body tissue, abnormal organ growth, a change in organ function. Exaggerated immune functioning symptoms, they can have allergic symptoms, they may have pain, they may have fatigue, They may have fever. And under clinical findings, the allergic response, we may notice a mild allergic response, or it could be severe. And then I have another bullet there for you, the autoimmune disorders. So symptoms here, they can range from vague findings to findings associated with organ failure. Suppressed immune functioning. Symptoms here would include report of frequent infections, poor wound healing, fatigue, malaise, and weight loss. Under clinical findings, the patient may appear malnourished or have wasting syndrome. We may notice chronic wounds, enlarged lymph nodes, and presence of opportunistic infections. Some common diagnostic tests, as far as primary testing, just off the top of your head, think of some things. What do you think are some things that we could use as diagnostic tests for these patients? We may look at a red blood cell count and a white blood cell count, so we may order a CBC, a complete blood count with differential. We may look at a C-reactive protein. We may look at their SED rate. And what does that C-reactive protein tell us? And what does that ESR or that SED rate tell us? I want you to look that up. If you're not familiar with those two tests, I want you to research that a little bit. Other diagnostic tests, we may look at some allergy testing, maybe even some genetic testing. We may check for a rheumatoid factor, Western blot test, organ function test. These are all things that may come into play and may provide us a piece to the puzzle that we need. I always look when I worked in the clinic, I would always think of each patient as a puzzle, and I had to gather up the pieces of the puzzle to put it all together to formulate a diagnosis of what this patient had going on. There are no routine screenings for the general population as far as for immunity. HIV screening is available for those patients that are high risk. And if a patient is high risk, let me rephrase that. What would make a patient a high risk for HIV? Maybe multiple sex partners. We used to worry a lot about it was men having sex with men. Now we just say multiple sex partners. Other things, IV drug users. So those are all things to think about that are specific risk factors for HIV. Clinical management, as far as primary prevention, we're thinking immunizations, avoiding high-risk behaviors, adequate nutrition, exercise, and infection control measures. Some collaborative care for exaggerated immune response. We want to remove the exposure. Provide airway support if we're looking at a patient with anaphylaxis. And then there's the pharmacology or the pharmacotherapy actions as well. And with that, what I want to mention is with these antihistamines, they are not always the most appropriate first line in older patients. And that is because they can cause drowsiness. They can cause them to be kind of disoriented, and we already worry in this population about falls. So that's just something, if you would have an order for Benadryl with a patient, it's not wrong if that's an elderly patient to just question the provider and say, you know, do you still want me to proceed with this even though the patient's a 99-year-old, whatever. It's never wrong. You know, you just worry about these patients, especially if they're going home on these medications, because a lot of these patients aren't able to care for themselves completely anyway. And then if we give them Benadryl, look out. So just something to think about.